Where can I find the right doctor? One who listens, is trustworthy, knowledgeable, and cares for me.
When life is uncertain, when you don't know what's next, we're on your side to help you find answers and understanding. With over 600 providers, SLUCare Physicians combine an advanced approach to medicine with a human approach to you. It's what we call informed medicine.
The gateway to the West, Cardinal Nation, St. Louis, Missouri, is the home to some of the most brilliant physicians in the world. These doctors are pushing science to its limits, healing patients in new, innovative ways, and doing it at the same time they're teaching the next generation of doctors how to save lives. Meet Dr. Philppe Mercier, a neurosurgeon at SSM Health, St. Louis University Hospital, and Cardinal Glennon Children's Hospital, who has found a way to use the newest technology available to get amazing outcomes for his patients. This is the science of healing.
Having access to multiple different types of technology is essential to neurosurgery. We don't function very well without it. It's not that we can't work without it, it's that we work far better with it. And our field especially has had a long history of interaction with technology. And in fact, our department has had a long history of interaction with technology. Stereotactic guidance system, which is essentially a GPS for the brain. I point to this part of the head or inside the brain. I know where I am on the MRI, was developed here. That's a device that's now in every neurosurgical operating room in the world. Neurosurgery is unfortunately one of those specialties that's very technology heavy, which makes it very expensive.
I was actually driving. I had the cruise control set on 72, and I went off onto oncoming traffic across the highway and missed two semi-trucks by 5 feet. My partner sat on both sides and hit a tree. And I had another seizure, and I don't know, somehow still here. So,
in some people, having seizures can result in a compounded brain injury and debilitating cognitive effects. Some people have seizures that are very debilitating from a lifestyle perspective. You can imagine if you had a 16-year-old with seizures, they cannot drive.
There's been times he's turned the stove on accident. I've had to pull him away from fires. I've had to pull him away from the vanity sink. I get him in the hallway, get him on a side, because they could become pretty intense.
Yeah, I was actually burning leaves in the backyard. My friend was over, and I was pouring the bag in there, and he goes, they were talking there, he's like, he's not looking right, and he's like, she goes, yeah, he's having one. I was falling, I guess, forward, and he had to pull me away and drag me basically by my feet.
It's hard for them to have friends and go to school because they always get sent home, so it's very debilitating to have multiple seizures.
At first they said he wasn't epileptic, and then he kept having them like back to back to where they were becoming grand mal. And so it was just, he told him, he goes, it can be gruesome, like it's a series of tests, like a bunch. I mean, we've gone through probably, he said it could take 6 months to a year. It's probably been about the year mark of the test.
If someone has seizures, we do a number of non-invasive tests before we ever get into any kind of surgery. And sometimes with that type of investigation, and if you add to that certain MRI findings, you can actually determine that their seizures are coming from here and operate very quickly. Other times it's much more difficult to tell. There are some people, for example, that have seizures coming from one temporal lobe and the other temporal lobe, or they're coming so quickly or spreading so quickly, we can't tell which side they're coming from. You cannot take out two temporal lobes. You can take out one, not the other. At the end of all those investigations, we get together and have a conference. We've done all of these tests to see where the seizures are coming from. How convinced are we that that's where it's coming from? And sometimes we don't know. Sometimes we really don't. Sometimes we have a clue, but that gives us something to target with surgery. So in that case, we have the option of either putting electrodes right on the brain in the subdural space. You can put a large piece of plastic with electrodes on the brain with the electrodes sticking out of the scalp. You can slide some under the brain. That gives you an idea as to what's going on the surface of the brain. Very much more sensitive than a scalp electrode. That technology has been supplanted by this idea to insert stereotactic electrodes, which are thin little wires that are sticks that you insert into the brain in very specific parts of the brain. And for that, we use robotics. It's impossible otherwise. So what those electrodes are doing are measuring from not just the surface of the brain where they go in, but into the brain where we think seizures are coming from anyway. And what the robot does is allows us to place those electrodes into the brain with sub-millimeter accuracy. Because you can imagine, putting a stick into the brain, you have to avoid critical structures, you have to hit your target, and you have to avoid blood vessels. So that allows us to do sub-millimeter accuracy, so it's fantastic technology and essential for any surgical epilepsy center.
I had the 16 holes drilled in my head with his robot, as he calls it.
We performed that surgery at Cardinal Glennon Children's Hospital, despite him being an adult, because that's where the robot lives. So Brady Rising was worked up by our adult surgical epilepsy team. And in his case, we actually had a hypothesis that it might be either temporal lobe. So our plan was to insert electrodes left side, right side. When robotic technology was developed, there were several companies that came out with these robots specifically for this type of procedure. There are areas of the brain you just don't want to touch. You don't want to get into the cracks and crevices of the brain because that may move your electrode as you're placing it into the brain. So the first thing that's done in order to do that is that we need a very detailed three-dimensional MRI, and that's what we use on a computer to plan where we're going to put our electrodes. So obviously at the end of our conference, we develop a hypothesis to say, okay, we're worried about left temporal lobe, right temporal lobe. We're not worried about anything else. So that is where we're going to put electrodes. Where are we going to put our electrodes? And we decide as a team where we want that information to come from. So we decide where to put them on a computer on the MRI. We merge that to a CAT scan that looks at all the blood vessels so that I can then switch the image from the MRI to the CAT scan and say, okay, is this electrode going to touch a blood vessel? And because the robot is so accurate, I can actually move it almost just 4 millimeters, avoid everything. And there are times when you have a ring of blood vessels and you're putting it right down the center. You cannot see anything. You're relying on the technology. So once that planning is done, the patient comes to the operating room, they undergo a general anesthetic, so they're asleep. They're fixed to the robot. So the robot has a very large, heavy base with a robotic arm, just like you saw on the space shuttle many years ago, that you see in car assembly lines. So the patient is affixed to the robot by pins that are placed in the skull that are physically attached to the robot. So the head is not moving with respect to the robot. And then on the end of the robotic arm, we place a laser and tell the robot where certain points of the face and the forehead are. And that allows the robot to determine where the patient is in three-dimensional space with regards to the end of the robotic arm. And then the programming that we had done previously with all of our plans gets input into the robot. We change the arm from a laser to just a tubular tool holder, and then off we go. We tell the robot, go to position 1, and if we want the electrode to come at this angle, in this direction, at this site, it'll place the tool exactly at that site. And what we end up doing is working through that robotic arm to drill right through the scalp, the skin, the muscle, the bone, through the inner table, right to the edge of the brain. And you could feel that as you puncture through. And then after that, we place through the robot an anchor, which is a small metallic piece with threads that actually screws into the skull. It gets put into the skull at the exact perfect angle where you want your electrode to go. Then we bring the robotic arm back to measure from the tip of the anchor in three-dimensional space to say, okay, we want the electrode is going to screw in here. How long do we let the electrode stick out? Then we take an electrode, measure that length, and just screw it in. It's that simple. And it happens very, very quickly. We could put an electrode in every 4 minutes. And that is a procedure without robotics that was impossible to do. Yes, there's technology actually invented at our university years ago by one of my colleagues that allows us to tell where the brain is in three-dimensional space, where the MRI is, and you could, using a handheld device, place anything anywhere, but not to that level of accuracy. So without robotics, it just couldn't be done. It takes an operation that would be impossible and dangerous can be done in 2 hours. The advantage too is that they don't leak spinal fluid out of these because the holes are so small and everything is so snug. So it's a lot better tolerated. You can imagine after a giant operation with spinal fluid leaking all over the place and a big incision and electrodes sticking out that you wouldn't feel very good to stay like that for weeks until you had enough seizures for us to gather the information you need. We've had one poor patient who was having 2 or 3 seizures a week on medication undergo stage 2 monitoring, and the minute we put them in, she stopped seizing. But she was comfortable enough to actually stay with those electrodes for weeks, and eventually we had to remove them. That's something that would have been too dangerous to do for risks of infection with the old kind of technology.
So it was trying to see if it was coming from the left side or the right side. Unfortunately, I had them from both sides.
So unfortunately, not a candidate for a surgical resection. But what we did offer him was a very new technology called responsive neurostimulation. Our investigations did localize the seizures to the hippocampus on both sides of the brain, left and right. There were multiple surgical options. He decided on the one which I thought was the best, which was this responsive neurostimulation. And what that does is that has us insert those similar types of electrodes using the same robot right down the barrel of the hippocampus in both sides in an operation. We connect those electrodes to a computer and generator that actually replaces his skull and sits under the scalp.
Here's the device that's in my head now.
And what that computer does is it constantly reads electrical activity from those areas of the brain that are very, very active. If it senses a seizure, it can actually fire a signal and hopefully abort that seizure before it happens.
I just go on here and you hit step 2, interrogate, and then it identifies, and I stick it right on top, and it tells you the quality on the computer and the status of how fast it's going. It's gathering the information, and I just leave the wand on the same spot until that green line is all the way at the end.
The advantage of that technology as well is that over time, you're gathering information over days to weeks to months. So eventually, after potentially 6 months to a year, we may be able to look at all the information we've gathered and say, hey, you know what? 95% of your seizures come from the left, with very few that start on the right. So if we offered then a temporal lobectomy on the left, if the seizures are still not controlled with this technology, then potentially we can do a better job at controlling the seizures overall. But I have inserted that type of technology in a girl with similar left and right temporal seizures, and she was so satisfied with it, she didn't need anything else.
I haven't had one other than forced ones from the hospital or from those big tests I've had. So they just gave me my license back finally. So
the biggest thing is an adjustment, because he's so used to living the life of, I don't know what's going to happen today.
Mm-hmm.
And he can actually take a deep breath now. That's what's been the biggest adjustment, is that he doesn't have to live in fear so much anymore.
It's very satisfying to actually rid someone of their seizures that they've had for usually years and years and years. And eventually, sometimes we can actually remove them off any of the medications that they're on. A perfect result is classified as an angle of 1, which means no more seizures. You could still be on medication, but there are some kids we can actually take them off medications and not even have the side effects of those medications. And for families, it's life-altering. That's what we've trained to do, and it's very, very rewarding. Whether they're pediatric brain tumors, whether they're skull-based tumors, whether they're intraaxial tumors or tumors within the brain, whether they're things you've heard of like glioblastoma or metastasis, which are tumors that come from elsewhere. Me and a number of my colleagues are experts in each one of these types of different kinds of brain tumors. Beyond intraoperative MRI, which allows us to remove as much of it as possible, we've adopted another technology specifically for a tumor called glioblastoma, which allows us to identify tumor while we're operating. What that technology is called is 5-ALA. 5-ALA is a chemical that the patient drinks. It makes them photosensitive for 24 to 48 hours. But what it does do specifically for glioblastoma is that it gets incorporated into the glioblastoma very easily for some reason. So what that allows us to do is, as we're operating, using white light, just like we used to see every day, we can then turn out the lights in the room and activate a fluorescent filter on our microscope and have the tumor glow bright pink. So normally when I'm looking into a field, meaning, I'm looking through my microscope into a brain, I see blood vessels, I see bleeding, hopefully not, but if I do, I stop it. And I can very quickly tell sometimes what's normal, what's abnormal. I decide using all my other technologies where I want to work, how I want to do it. But there are some tumors like glioblastoma that infiltrate. So yes, they form a solid mass or necrotic or liquidy mass in the brain that does not have any brain tissue in it. But we know that that type of tumor has grown cells that grow into what looks like normal brain. And glioblastoma is one of those tumors that has been shown again and again to have improved survivability if you remove as much of it as possible. But again, as safely as possible. So what this does is lets us change our visualization from just white light to this floor. And what happens is that the tumor glows bright pink. The brain behind it turns black. So it is very easy to see that this is tumor, or at least brain with infiltrated tumor cells growing through it. And then it's up to us to decide to resect it, how far to go, because at some point we know, well, there's brain that does this specific function. At this point, I can only go so far. But what it does is allows us to really get to the absolute edge of those safe margins and resect as much of it as possible. And that has been shown again through multiple studies to improve outcomes of patients with glioblastoma. Glioblastoma is unfortunately almost universally fatal. Most people don't survive beyond anywhere from a year and a half to 2.5 years. However, with maximal surgical resection, using whatever you can. If you're just taking out extra brain, which is sometimes very challenging to do depending on where the tumor is, whether you're using an intraoperative MRI or 5-ALA, whatever you're doing to remove as much of it as possible has been shown to have great benefit and buy people as much time as possible with their families, despite having such a grim diagnosis. The principle of oncology is that you don't just remove the area of skin or tissue that has the tumor, you remove a little extra in case there's a straggling cell here and there that's grown into it. That's a good oncologic principle anywhere else in the body, but it's very rarely applied to the brain. You just can't take out chunks of brain. You have to know where those borders are, whether you're doing an intraoperative MRI scan, whether you're using 5-ALA or anything else for that matter. And you have to know where the functional brain is. So all the studies that we do, as part of our surgical epilepsy program to determine where function is, we actually apply to brain tumor patients to say, okay, this area of the brain is very important. The tumor is right beside there. How am I going to ensure that I preserve that functioning brain? What kind of tips and tricks do I have? So we often use technology and techniques from one type of surgery to apply to another to achieve our goals as safely as possible. That's what we've trained to do, and it's very, very rewarding. As SSM thought enough to invest in a brand new building, as a neurosurgical department, we asked them to assure us that there would be room for an intraoperative MRI. What that is an MRI that's actually in the operating room. What that allows you to do is to start an operation on someone, decide, I'd really like to know what an MRI would show. Have I completely resected the tumor? How close am I to very functional tissue? An MRI would be very, very helpful at this stage. So you have two options if you're thinking that. One, do I close the patient, wake them up, do an MRI the next day, and then take them back to the operating room several days later? But using intraoperative MRI technology, what we can do is literally put 2 sutures in the scalp and literally place that patient in an MRI, get an image at that time. And once we're done with the MRI, we take them out, right back into the operating room next door, and keep operating within 5 minutes. And what I can tell you is that some tumors look exactly like brain. They look like brain. They don't have borders. Someone once told me it's like taking a pat of margarine out of a brick of butter. It looks very, very similar, if not exactly the same. So we have to use a number of clues beyond, purple tumor, yellow brain. Some of those are texture. Sometimes a tumor has an unusual woody, harder texture. Sometimes it's very, very soft and is abnormally soft and clearly not normal looking brain. We use our stereotactic guidance, which was invented here, which allows me to point to it and look at the MRI and say, I'm pointing here, that's where I am on the MRI. So therefore this is tumor and this is brain. So we use a lot of different types of technologies, but in the end, you've been working in this cavity trying to preserve brain, take out just the brain tumor, and sometimes it's very hard to tell. Am I done? Am I not done? That's the point that you really need a new picture, because that tells you whether you're complete or you're not.
Dr. Mercier did his first resection in her 7th grade year.
It was a very life-changing moment for me, and it just dawned on me that it's not just the seizures or the epilepsy anymore, it was something else. I said I had a rock in my head that was growing, and let me just say, I think I bawled my eyes out going from the hospital home.
I have known Mary for a very long time. So I got to know her, I would say 4 or 5 years ago. She presented to the Children's Hospital with seizures. And we had an MRI demonstrating a tumor in the left temporal lobe. The first operation did was to remove the temporal lobe, all aspects of the tumor. Our scan afterwards was very normal. We didn't have any abnormal tissue. Part of any follow-up for a brain tumor patient is to repeat imaging every so often. There are some tumors that have a tendency to come back, and hers does. So despite us removing all the MRI abnormal signal, she still had some developments of some areas of concern that grew over time. We had to return and take those out.
He was very optimistic, and through the entire time since the first time he met us, there was a sense of just reassurance with him and his nurse practitioner, Anne. And it's hard, when you have a situation like this with a brain tumor that, when you go out into the average world, everybody just, oh my gosh, you're dying. In Mary's situation, it is routine brain surgery. She had her last brain surgery here in August, and she was home in less than 48 hours.
Mary had undergone successive scans over a year. Everything was fine, no new symptoms, perfectly normal child. And there was an area that started to be of concern in the depths of the bed of the resection cavity. At first, it was actually concerning that she had developed an aneurysm there. So we did all the investigations for that, not an aneurysm, it's a growing tumor. So at some point we had to decide, should we just resect it? Again, if we remove every last cell, she should be cured. So what I suggested to Mary is that we wait a few extra months, do it during the summer after the intraoperative MRI is installed. So I took her to St. Louis University Hospital, where we took her to the operating room, opened the same incision that we had opened before, got into the surgical bed, identified where we thought the tumor was using our stereotaxy or GPS, removed abnormal tissue, but again, after multiple surgeries and scarring, everything looks abnormal. We removed what we thought was the lesion and placed it. While she was still open, while the operating room equipment is still all available for use, we put a bag over the sterile field, put her in the intraoperative MRI, and scanned her and realized that we had completely removed the lesion. So then I could take her back out, close, send her on her way. She went home in a day.
It was very nice for us to know that one surgery was only going to be needed since we had the MRI and the new technology, and the hopefulness with the more current technology that we possibly would be able to get a better cut and not have to keep doing this.
Before she was even closed, I could call mom and say the tumor is all gone, rather than, oh, there may be a little bit left. It's still an area of concern. We should keep an eye on it. At this point, we know that everything's removed and everything's all gone.
Having such an exceptional surgeon here in St. Louis that we are able to grow with from, Cardinal Glennon now to as an adult, but he is there to rally behind us and encourage her. He's encouraged her. He looks at all her pictures every time she has something else going on in her life, and they're encouraging her to head off to college and live her life in independence and being able to accommodate her for her medical testing back here in St. Louis.
It's very satisfying for everybody. It's, as a parent, I think it would be very reassuring to know that, okay, the operation's done, but it's done. It's not just done, the goals have been achieved. Rather than the operation's done, now we have to wait for the MRI the next day to see whether there's still an area of concern and decide whether or not to do another operation, or know that there's something abnormal in the back of our minds for the next 3 months, 6 months, 9 months, 1 year. So it provides a lot of relief for everybody.
She made it through the first 3-month checkup here in October and no signs of any return. And then she'll be going through her 6-month follow-up here in January.
That's what we've trained to do, and it's very, very rewarding.
I completely trust Dr. Mercier now, and whatever he says goes.
His bedside manner is fantastic. He makes you feel comfortable. He makes you feel heard. There wasn't a time where I didn't have a question and he didn't answer it or make me feel like I couldn't ask him a question. I mean,
being part of a system like SSM, St. Louis University Hospital really represents that quaternary referral center, right? Where you have primary, urgent cares, primary hospitals, you have secondary hospitals, tertiary hospitals where a lot of different types of complicated procedures are done. But for some things where you need that level of technology and that level of expertise to use it, really you have to go to a place like, and it's nice to be at a place where I can do the work to the top of my field. I find that very rewarding.
I would not have her go anywhere else for her care. She will, she drives back and forth from Indiana to St. Louis for her care as we go forward. So as we say, Dr. Mercier and Mary are going to grow old together.
Yes, yes. That is the number one thing.
So he better not move.
You better not move.
All the doctors and nurses have just been phenomenal, all of them.
As a quaternary referral center at St. Louis University, it's not just neurosurgery that operates with the latest gadgets and technology at the top of our field. I'm privileged to work with a number of other SLUCare physicians who are all experts in their fields and all work at the top of their field. There are operations we do at St. Louis University Hospital. They're only done in a few centers globally because they just don't have the expertise.
I really feel it's a personalized touch that we have, and I think the mission is well lived through the healthcare system that we're in.
They've had a great team. I mean, to the people who came and wrapped his head up, they would come in and check on him, to just the EMU coordinators like Lauren, they were all fantastic, all of them. If I had any questions, I could just call them, or if I did have a question about a nurse or I wasn't sure about something, I would call them, or they would come in and always answer questions. So
we have had nothing but excellent care from the SLU physician group for the entire time that we've been receiving services at Cardinal Glennon or St. Louis University. So every provider, every nurse that we've encountered, whether it's the radiology staff, the lab staff, they're always there to be accommodating.
Is trustworthy, knowledgeable, and cares for me.
When life is uncertain, when you don't know what's next, we're on your side to help you find answers and understanding. With over 600 providers, SLUCare Physicians combine an advanced approach to medicine with a human approach to you. It's what we call informed medicine.